Thank you very much to everyone who's still here and hasn't gone shopping. So fantastic. So so I wanted to talk about compassion-focused therapy, and thank you to all the people who've been involved, both helping me to deliver it, funding it, and obviously all the participants as well. So we hear the word compassion used quite a lot in terms of good quality of care, but compassion-focused therapy is a very specific model of therapy. It comes from the School of Evolutionary Psychology, and it was originally developed for individuals who are experiencing high experiences of shame. And there are different people, different academics who've looked at this, but I particularly followed the model that Paul Gilbert, who is a British psychologist, he talks to and advocates. So the model of compassion-focused therapy, because it's evolutionarily based, it provides an understanding for us that our brain's responses are tricky. They've been evolutionarily designed to pick up on things like threat. So if there's any doubt in the system about what we should be focusing on, the brain automatically jumps to threat. And CFT has been used across a number of mental health settings and mental health disorders, and also in acquired brain injury. So why should we use CFT with people with dementia? Well, if any of you were lucky enough to get room upstairs at 1 o'clock and heard Agnes Houston talking, she spoke about being in a constant state of hypervigilance. And so this experience of dementia as being a very real threat is something that people live with all the time. And so it has a face validity to it. And previously I've used CFT with individuals who've had dementia, and also with a one-couple setting. So what I wanted to do was to expand it out and say, well, is it possible to carry on this work and use it with a number of couples within a group? So we're kind of getting the benefit of the relationship that there is between husband and wife, and also between the peer support for people. So that's what I explored. Jeff Huggins yesterday was saying that the people who have the best ideas are the people with the disorder, or the people caring. So I wanted to get patient and public involvement straight away. So these are some of the concepts that people came up with, that it has been helpful in the diagnosis of dementia and accepting the diagnosis. The idea that groups of people with similar levels of ability would be really helpful. And there were people coming up with ideas about how to run the sessions, what duration they should be. And somebody pointed out to me it would be really good to have other people with dementia because you don't have dementia. And one chap said to me, you might be crocked up, but you can still talk to people. And so it's really important to still pull on the skills that people have. And one of the ladies said to me, I think it's a wonderful idea. We can all meet up and talk about things. And my husband can tell you how I'm getting on. So very much that sense of the kind of, the whole is greater than the sum of the parts with relationships. So relatively simple inclusion and exclusion criteria. I'm only in clinical practice. I'm not part of a big research body. So we included people who'd received a diagnosis within the West Suffolk Memory Service within the previous 6 months, who had any form of dementia. So CFT is a trans-diagnostic model, so I felt it was really important that actually we just included people with any form of dementia and mixed them up. Very little exclusion criteria, basically, if you didn't have somebody who could come with you, and if you weren't able to access the communication either through sensory difficulties or no English language. So a group consisted of 4 couples, where one of the people in the couple had a diagnosis of dementia. And I've run 3 groups so far. 2 of the groups, it happened to be all of the husbands with the person who had the dementia, and in the 3rd group it was half and half. So it was a very typical demographic for the area that I work in. So they were all white, all British born, and they all had English as a first language. Ages ranged from mid-60s to late 70s. And the screening test that we use is the Addenbrooke's cognitive examination. And the scores that people came into the group with ranged from sort of 55 to 82. So it's a mild to moderate kind of category. And a range of dementias, as I said. So this goes through, if you're particularly interested, groups 1, group 2. So basically this is just showing it's a range of ages, lots of comorbidities, and a variety of diagnoses of dementia. So group 1, group 2, and group 3. And obviously, if you're particularly interested, these will come out. So the method that we used, it was 6 sessions for 2 hours once a week. Lots of soothing rhythm breathing. So I haven't got time to go into what is compassion-focused therapy, but that's something you can very much find out on the websites. So soothing rhythm breathing twice per session, seated in a circular format. We took a very long break for tea and coffee. Lots of visual imagery techniques we used, and compassionate smell techniques as well. So kind of attacking the senses from every possible modality. At the end of the session, at the end of the course, patients received a CD which had these techniques on them so they could take them home and practice. And something that I nicked from an acquired brain injury group that I went to was about giving out postcards at the end. So people pick a picture that is meaningful to them, a postcard. They write a message to themselves on the back that is something, kind of a mantra, something to do with compassion that they want to say to themselves. I keep them for a month, and a month later I post them out to them. So they get a message in the post from themselves. So you'll see some of those examples later. So if I go through the kind of the course content, so the classic Cft themes I included were a little bit of psychoeducation around the evolutionary brain, our innate sensitivity to kindness. So we don't need to worry, can you do this? Do you still have this skill? This is inbuilt in you. We're naturally designed. There are areas of the brain, apparently the periaqueductal grey area is naturally the part that picks up on nurturance and maternal kinds of behaviours. We also covered information around why the brain is tricky to regulate and the fact that it's not your fault that you may pick up on threat all the time, but it is your responsibility to do something about it. I spoke to the 3 circles model, which is a kind of model which explains that we sort of have 3 drive systems, 3 emotion regulation systems, one that focuses on threat, one that focuses on drive and resources, and one that focuses on compassion and our affiliates. We learned about flows of compassion, fears and blocks to compassion, and I picked up lots of the resources from the Compassionate Mind website. Paul Gilbert's very generous with all of his resources, so do use them if you want to. Now, what adaptations did I need to make to the CFT? Well, we discussed dementia specifically as a threat. Specific themes that come out for people, things around anger and guilt, embarrassment, feeling ashamed that, you know, your husband is irritating you and he asks that same question over and over again, and sharing that admission, it can be quite difficult for people sometimes. I used a lot more visual images during the sessions than I would do normally to discuss current emotional responses. We did our breathing practice more frequently, so at least twice every single session. Much longer breaks in which people chose sometimes to come and help to make the tea and to make the coffee and those sorts of things. And we used lots of compassionate reminiscence, again, using sometimes smells that people had brought in, oranges, talking about Christmas, all sorts of things. So these are some of the pictures that we would use to talk about what does that stimulate for you. So right here, right now, what is that? Is that building up for you? Where are you noticing that feeling? Is it in your stomach? Is it in your head? What's happening right here and now? So absolutely no need at all to tap into memory. We're just talking about a here and now experience. Which of these images kind of speak to you? Which ones are you finding positive? There may be much more simple ways of showing compassion than necessarily lots of big hugs. But again, one of the things that Agnes was saying earlier was that as things feel more scary, what she feels that she needs, and this is common for lots of people, is more empathy, more compassion, more hugs, more emotional reaching out. So again, more images that we're talking about the flows of compassion, the reaching out of compassion. And then some pictures to sort of say, well, what is compassion? Compassion is not necessarily about being nice and fluffy and friendly. Sometimes it might be a kind of whispering of advice in your ear. It might be sharing with you in the distress of how difficult something is. It might be kind of stargazing, going, do you know what, you're doing pretty well at the moment, you're pretty amazing. Or it might be kind of taking you in hand, saying, actually, in your best interest, you need to knuckle down right now. So just lots of visual images as well as the verbal things. So I've talked a little bit about the content being compassionate, but also the process was very compassionate. Having kind of discussed within the group very explicitly about compassion, it was really important that actually the process was the same as well. So I had a number of members who fell asleep during the sessions. They weren't able to remain alert. And it was important that the group were happy with that and that that was tolerated. And it was quite a natural experience that actually that was tolerated by the group. But very importantly, that that was witnessed by the relative, by the spouse, that that was okay. Nobody was getting upset. I had one gentleman who had a very severe linguistic variant of Alzheimer's and obviously having a lot of difficulty with aphasia and speech production, but space was given very much for him to be able to try to communicate with the group verbally. Lots of tolerance of repetition. And that was made very explicit that actually it's fine to say the same thing over and over again, because actually it's really helpful for the group for us to get a sense of, okay, this is a theme that's coming up for us again, so that's fine to repeat it. A modelling of reminiscence and that opinions are more important than facts. And there was a lovely example of compassion with visual hallucination. This screensaver popped up in the middle of one of the sessions, and it was really distressing for one of the chaps who was in the group who had Lewy body dementia. And he became very anxious and very uptight about what is this? And he started saying, well, what is this that's happening? I don't understand. And all of the other members in the group just very naturally, very calmly responded to him, including the other people who were suffering with different forms of dementia, saying, I don't think it really means anything. I think it's just different colours and it's probably part of the computer and it's fine and it's okay. So the compassionate postcards that I spoke about earlier.
You have 3 minutes left.
Oh, fantastic. Thank you. So these are some of the comments that people put to themselves that they wanted to receive in the post in a month's time. So, you know, you may be able to pick out ones that were from the carers and ones that from the person themselves with dementia. So this kind of sense of everything's going to be okay, just support each other and we're together forever. Okay. So a very, very quick whistle-stop tour of some assessments. So I attempted to do a little bit of assessment. One person dropped out basically because his wife wouldn't come with him, but lots of people couldn't attend every single session. That's just the reality of kind of the people who we work with. So I did some mood ratings with the HADs. 2 people increased in anxiety, but everybody else stayed the same or reduced. So that's a kind of a little visual of that. And with depression, nobody got any more depressed, and actually quite a number of people became less depressed. In terms of distress rating, I think this is really difficult to measure, and I actually think it measures a process of kind of grief and acceptance. So there was a shift depending on where you started, really. So the compassionate mind skills, could people acquire them? Well, yes, they could. Everybody was able to acquire the visual imagery skills. Everybody was able to acquire the soothing rhythm breathing skills and to decrease their breathing rate. So physiologically, they were able to self-soothe. This is starting to kick the brain into a self-soothing pattern, so it's working. So in conclusion, it seems as though that group CFT for couples, which includes any diagnosis of dementia, is feasible to deliver. It's possible. And not only that, but it's acceptable, with positive experiences of being in a group. And there seem to be positive benefits on mood and compassion skills. So, thank you very much.
Thank you very much, Rebecca, for the successful implementation of this therapy on couples with dementia. Are there any questions for Rebecca? Again? Oh.
Yeah, I don't know if you can understand me here. I'm Marco from the Netherlands. So this is the concept of mindfulness, but then a bit adapted, I think.
Yeah, I think it's very similar, taps into very similar themes to mindfulness, but it adds more of a kind of an evolutionary theory behind it. Yeah.
So more communication afterwards.
Yes, yeah. So there's a lot of conversation about why it is that you may be feeling in this particular way, and then also doing the skills as well. So it's kind of two aspects as well.
Yeah, and you said there should be at least one person with dementia in the group. are all couples with one person
Yeah.
having dementia?
So all the couples, either the husband or the wife, had dementia. Yeah.
Yeah, that's nice to see, because I'm also working on that idea, but then select groups, but you can combine it.
It seems possible, and I think if you work to the theory that it's just bringing up distress, it doesn't matter so much what's causing that, because it's the kind of commonality. It goes back to what our Irish friend was saying this morning about this is a struggle with survival. And actually, if we can see that that's a common theme for everybody, then we can work with that. I've published an individual one in the Neurodisability and Psychotherapy, so the chap who I worked with on the individual, but I haven't published the group stuff yet.